I welcome you all on behalf of Neurotrauma Society of India's third webinar since we started the webinar series like 2 months before only. And the last two webinars were hit and it is seen multiple times of the YouTube. I got many requests from the students that we have to start the YouTube channel also, and we are putting all the recorded videos, all the sessions on our YouTube channel also. And we are very fortunate that we have two legends of cysternostomy. The person who himself has introduced this concept is with us here. And our panelists, Dr. Chinmay Das and Dr. Vikram, are here. Dr. Vikram is a senior consultant neurosurgeon in Coimbatore. He is practicing for very long in neurosurgery and has been very instrumental in the Neurotrauma Society of India. He has been actively involved in Skull-Based Surgery Society also, and is very active on academic front. And Dr. Chinmay Dash is professor neurosurgery at AIIMS Bhubaneswar, and I've just seen his profile today and very surprised that he's doing a lot of research work in neurotrauma itself. So I welcome you both, Vikram and Chinmay, and I request you to take the dais and introduce our legendary speakers, and then we'll start.
Thank you to Deepak for the opportunity, and it's a wonderful gathering and one very important topic. So without much delay, let me introduce our two legendary speakers. Dr. Ayub Cherian, he is known to everyone as the founder of Cisternostomy in the Indian neurosurgical community. He is the Director of Neurosciences, Parle University, Gujarat. He is the Chairman, Innovation Center Committee, WFNS. He is the General Counsellor, Asian Congress of Neurological Surgeons. He is a member, Anatomy Committee, World Federation of Neurosurgical Societies. He is an inventor, of course, we all know about the cysternostomy, about the cleaning and the cooling theory, and the design of the modern microscopic equipment like the hyposcope and the water knife. So, I mean, this is as short as an intro I could give. It could go on for the entire hour, but we need to move on. And Dr. Parthivan, do we need to introduce him, sir? I think
you can introduce after Dr. Ayub,
Yeah.
you need not introduce him. We all know about Dr. Parthivan.
Yeah.
Yes,
So there's not
it's
much to
customary.
talk
So
about.
it's
Everyone
customary.
knows
So
about him as
yes.
well. So, but in short, he's a very senior consultant neurosurgeon known wide across the country. He's a course director of the Diploma at National Board of Examination. He's a part of the Department of Neurosurgery, Kovai Medical Center and Hospital, Coimbatore. And his entire career is marked with excellence in both brain and spine surgeries. He was probably the first to demonstrate the pedicle fixation way back in 90s when there's hardly anyone doing it. And there has been illustrious contributions, a lot of awards and accolades, like leading spine surgeon recognition from Professor H. Michael Meyer and at Synthesis at India Spine Vision. He's been examiner of neurosurgery at various NSI courses, and he's published many articles in the Indian and international journals with a lot of contributions in operative neurosurgery, which many of them I have seen and you've learned from him. So, I mean, he's a legend and he's an excellent orator and teaching faculty in spinal surgery in India and abroad. And 2015, he obtained the DNB Neurosurgery postgraduate education in the Kovai Medical College Center and Hospital, Coimbatore, Tamil Nadu. And is one of the founding members of the Neurospinal Surgeons Association of India, and he's in the editorial board of the journal as well. So, and he has developed many equipments and instruments like double hook retractors, and the list can go on. So, Dr. Parthivan, it's an honor to introduce you, and we are waiting to hear from you. So, most welcome.
Thank you very much, Das. Thank you very much. Thank you.
So, if you permit, sir, we'll start with Dr. Ayub first. And as you decide, sir, I think Dr. Ayub talk first, and then we'll go for Dr. Parthivan talk.
Yeah.
Will it be okay, sir?
Yep.
Parthi, how do you want it? You want me to talk first?
You start. you are the innovator. You must.
Well versed in cysternostomy. So I think it doesn't matter. However,
my net is a bit suspect. So I'm having this from the farm. So my net is a bit suspect. Please apologize for that. I'll go ahead and share a short talk. I mean, Parthi, I can only tell one thing, that if it was not for Parthi, and a few other, Parthi mainly, and a few others, the cysternostomy concept would not have taken off because I had, in my ways, made it so complicated and, in a way that, not a lot of people could adopt it. So I would say my part of it, but the whole credit for getting cysternostomy all over the world goes to Roy, Wang, and of course the main person is Parthi. Parthi, I met him. We had this argument about 15 years back, I guess, maybe 12 years back, and then after that, Parthi took up cysternostomy, and that is how you should know that piece of history as well. So right, so let me share my presentation. Can you see my presentation? Can you see my presentation?
Not yet come, sir.
Yeah,
Sir.
Yeah.
It has come?
Yeah, please start, sir. You can see your presentations.
Right. So let's start with this CT. Okay. Now, I'm sure if we can all agree that there's a lot of subarachnoid hemorrhage. There's a large burst lobe. Burst lobe meaning subarachnoid hemorrhage. I mean subarachnoid, subdural, and lobar hemorrhage here with severe compression. You can see that the midbrain at this region is really compressed. There's just blood in the cisterns. You can see blood in the cisterns. Actually, you can see here blood in the cisterns. And there's a lot of blood even under the tent. So, I mean, I'm sure what would most guys go for would be, I mean, this thing is turned. Actually, this thing is the scan is turned. But yeah, so yeah, so this is what I wanted to show you. Let's go ahead. And I don't know. Yeah, so this is done by one of my residents who sent this. I mean, these days, I don't do this. I don't do cysternostomy as often I used to do, but this is done by somebody who later, where somebody took a recording from the phone. And I don't agree with everything that this person is doing, but essentially the philosophy is the same. Go down to the base, take off all the bone. That is the most important thing. So when you take off all that bone, you're removing almost 30 ml of bone. And after that, I would open definitely here, not, you can see my mouse where and that is where I would open, and I would generally take it upstairs like that. But this person has opened in the top itself, but he's made the right thing about removing as much as bone. I would have removed more, but you see, it's such a bad injury. And this chap is just out of training. I mean, he's not a micro neurosurgeon or anything. He's just out of training. So he's gone ahead and now you can see that what is seen right now. You can see the burst lobe there. You can see a lot of blood there. The brain is, I told you, when you are removing the base, you are removing almost 30 ml. So I am seeing that brain is there, a little bit of, so he's open just right there. That's a good thing to do. Cysternostomy, I have seen that everybody does cysternostomy in their own way, but earlier I never used to approve of everything, but after Parthi, what I realized is there is so many ways to skin a cat, so you don't have to worry about it. So Now this guy is gone into the opticocarotid cistern. So that is optic, and lateral to the optic is obviously the opticocarotid cistern. So he's opening it with the number 4. I mean, with a Penfield retractor. I never do that. I usually use a close scissor to puncture and then open. That is how I do it. But he's obviously, and this is how he goes. That's optic now. That's a little bit of too much traction. I wouldn't again approve of that. But then what finally matters is that you see that brain. That's really lax and, pulsatile. Very lax and pulsatile. That is what finally matters. Okay. This is, at the end of the day, he's delivered, and all that, the brain is completely down, and he can put his he can put his bone flap back without any problem. Now he's you see the pulsatility now. Okay, so this is something sent to me by, so that is how it looks like. It is it doesn't look fantastic. He's gone to the other side also with a mini craniotomy. Yeah, so you can see that he's gone to the other side with a mini craniotomy, and this is how the guy looks like. Okay, so obviously it is an excellent result. Now, this is another thing. This is another case. Again, you can see how much bad this one is. This is something I have shown before as well. Hyperacute subdural with very low GCS brought in. And you can see here, what you have to see here is the herniations already happened. You can see that is a midbrain, and you can see the pons. There is CP angle system is widened because of the herniation. And so this is something that we did. And you can see the bone is all removed up to that orbitomeningeal band there. I cut the orbitomeningeal band. So I would call now, these days, I call it type C because orbitomeningeal band transcavernous peeling, I call it type C cisternostomy. But the type C cisternostomy is rarely required actually. But here I did type C cisternostomy because I had to unherniate the temporal lobe. So you can see the temporal lobe is all full of blood. It's just blood. So I'm going lateral to the carotid. I can even go lateral to the third nerve. That's a posterior clinoid process. So you would see the third nerve there, because the third nerve is really herniated because of the temporal lobe. So you go all the way, that's the basilar artery. So that's the basilar there. And you put your feeding tube in there. And now you go ahead and unherniate the temporal lobe. So that's the middle cranial fossa floor and the tent. You are slowly pulling the temporal lobe up. And that's what you do. That's very important. Unherniation of these temporal lobes are very important. Now you can see there is that the CP angle cistern is still wide, but there is no herniated temporal lobe there. So, and you will see this patient. This is the guy. Before even the stitches are removed, this is the guy. So that is how this was done in Karat. So this is another case. You can see this is one of our earliest cases. I mean, this is one of the cases which where we were still doing decompressive, and then you can see a little bit of bone kept back, and you can see how bad is this one. It's people tell me this. You haven't seen real brain edema, but this is as bad as it can get. So you can see the cisterns are open here, while the cisterns are not open here. That's the most important change that you see. The cisterns are completely open here. Here there's no cisterns at all. Absolutely nothing, just blood. Okay. So, and this is how the guy looks like. Yeah, so now I wanted to show this small clip. When we started off, there was one problem. People were not ready to accept it because people were asking us, where is the evidence? Obviously, something new would not have evidence immediately. I mean, so that was any new things. Can you hear the video? Can you hear the video? Can you hear the video?
No, sir.
Not yet, not yet. We can't hear it as of now. You can see the subtitles, but you can't get the audio.
The subtitles, maybe I can read it for you, but the audio is not coming. I can read it for you. Oh, this is what I wanted to tell you, that anything that comes new
Yeah, we
is,
could get it.
yeah, it can never be peer reviewed. So for 15 years, I struggled with this because my perspective was it was common sense. I'm doing something that's pure common sense, and people, I mean, I saw that people are not getting it. And it was because of this mentality that unless it's peer reviewed, you will not accept it. People will not accept it. It took such a long time for us. I mean, I'm sorry for, because I did not accept, I did not understand this. And probably I would say Parthi, Roy, Wang, and all these papers got it into peer-reviewed papers and made it accepted right now. But otherwise, I would have gone on without that, and it would have been not accepted even now. So it's a thing. So the history of Cisternostomy, it was pure serendipity. I figured it out completely. I did not, I did not know that it was a case of trauma. I thought it was a case of aneurysm, and I went operated just like an aneurysm. And I figured it out. I figured out that the brain swelling came down, and that is how it proved a stimulus for further studies. I applied skull base and vascular microneurosurgery into trauma accidentally. And then I started thinking about it, and I figured we discovered CSF shifted edema and the role. I mean, obviously, after that, we figured out the role for CSF for cleaning and cooling, although we didn't have any basic science research. So these are a few of the first cisternostomy series. You can see the CP angle cistern is completely wide, and this is one of the most important indications. You can see the midline shift here. You can see the contusion here. You can see the subdural here. The midline, I mean, I always say, there's a little bit more, the midline would be out of the brain, out of this head. That is how bad midline is here. Guys, herniated, okay? So that you can see the upper herniation here. The upper herniation is clearly seen here. Now you see the same guy, bone replaced, okay? There's the temporal lobe contusion is still there. And this is how. This is the guy sitting up, okay? The midline shift is just coming back. No decompressions, okay? And okay, I see Afsal also. Afsal's from Germany. and he is been doing cysternostomies in Germany. So there's another one, relative of the Nepalese football captain, okay, airlifted to us. The most important thing you have to see here is the cisterns are kind of finished off. I mean, nothing, okay. The cisterns are so very high pressure. So you can see we kept the bone flap back. Patient is completely okay even after maybe 15 years now. Okay, no problems riding scooters. And this is another one I wanted to show you. This is as bad as it gets. Okay, you can see how this brain is. A lot of people tell me, oh, you shouldn't operate these cases. GCS4 and E1, V1, M2. Okay, I was pretty young at that time. We went ahead with this, and you can see a lot of people ask me what happened. You see, this is surgeon induced, because this is how much hard we had to kind of pull the brain up, because the edema was that bad. But we got in the cisterns. Once we got in the cisterns, we could keep the bone flap back, and here she is. Now, this time, after 15 years, I went to Chitwan. When I turned 50, I left from Karad, and I spent 5 to 6 months in my farm in Chitwan. And this lady came to see me. I have a photo of hers and her almost teenage daughter, who was a little kiddo. Maybe Afsal, do you remember this lady that were you there in Nepal when this lady came? Because I remember you were there in Nepal. We took some photos.
I remember. Yeah.
Yeah. So this lady came to us, and we took a photograph with her. And this is how bad you can get it. And then, she's completely okay. She doesn't even have the third nerve palsy now. Okay. There's another one. You can see how bad that is. You can see how bad that is. It's herniating. The CP angle cistern is widened. And here she is in my room after the cysternostomy is done. Okay. Now, we got so many of these. I don't need to prove a point here now. Okay. I mean, I'm sure a lot of you guys are already doing. We have Parthi, who's got massive experience with cysternostomy. You got so many others who are doing it, and they know I don't need to prove any points here. This is from Czech Republic. They showed me how the ICP dropped from 48 to 11 while doing cysternostomy. Okay, you can see the massive decrease after they opened the cisterns. Now there's photographs and so many more other pictures from everywhere. Now, this is one of the videos from my very early time. It's 10 years back, okay? And these are some of the real edematous brains that I wanted to show you. So you can see I go to the very base, and I take out all the bone down there, and then I put a stitch there down at the base and pull and make the incision right down there, okay? And this is a brain which is as bad as you can see the brain coming out right now. So this is as bad as it can be. But you've seen that I'm opening only about 2.5 to 3 centimeter, and I'm going into the cisterns, okay? That's most important. You should be oriented where the cisterns and all this blood that comes out, okay? Yeah. All that blood that comes out, don't worry about it. Only thing is, don't push too hard to, create injuries, vascular injuries or nerve injuries. So you can now see that that's the optic nerve, that's a carotid. Okay. There was contusion of the frontal lobe, and I was just going through a 2.5 centimeter incision. That's a carotid, that's the optic nerve. All right. Now we have managed to open the cisterns there. Now that's a contralateral optic nerve. Okay. Now I'm going in between the optic and the carotid and into the basilar. If you see, we've taken less than 5 minutes to reach there. after the dural opening into the basilar. That's the basilar. It's taken 5 minutes. Okay. You can see when is the dural opening. It is 21:15. Okay. Sorry. 21:12 is the starting. 21:15 is the dural opening. Uh, 21:18 is where I'm on basilar. So before the dural is 7 minutes, I'm onto the basilar in such a tight brain. Okay. So that is, that was 10 years back. So this is because we were trained as vascular surgeons, and I would want, Parthy is an excellent vascular surgeon. I see a lot of seniors from your side who are excellent vascular surgeons. You are the guys who should lead the way. And if you expect a second year or a third year resident to do this, getting into the basilar in 7 minutes or 10 minutes, that's going to be a bit difficult for them in the initial period. So now I'm just going to get a break and I'm going to go in again. I put in a catheter there, and then now I'm going to open the dura. Okay. Now I got the break. Now you see the brain, how tense it was. And now I take it out. Now I got the break. Okay. I can go in now. The brain which was so bad, it's not so bad anymore. Okay. And then I go. See, everything together is 21:12 to 21:28 now. So I wouldn't be this under magnified anymore, but I guess it's experience which comes now. I'm going in, further opening the cisterns, going in under high magnification there. Opticocarotid window, you can see the basilar there. That's a prepontine cistern there. That's a temporal lobe. You can see the basilar clearly there, all the prepontine cistern and the basilar there. That's the membrane of the liliquest, opened clearly. Now you put in the feeding tube. Till about 3-4 years back, I was putting in a number 8 feeding tube, and you can see the brain now. Okay, you've opened everything. You got hemostasis. The brain is nicely pulsatile. Okay, imagine when you opened, if you had made that full opening, this brain would have been bulging out into your face, So now it's completely, and another one, I just wanted to show you. Some people ask me, what about there is no subdural at all, if it's just looking like diffuse brain edema? Well, if the cisterns are not seen, you must go for it. Okay, and you see, when I open, you will see how bad is the brain edema. This is another one. Again, you'll see how much bad is the brain edema here. You can see it coming out. Again, I have taken a lot of the bone there. That's helping me. So now you'll see that brain is completely lax and pulsatile. I have put the feeding tube there, and the entire opening is only this much, about 2.5 centimeters. That's all I need. So some of the surgical videos, but I think Paparthi is going to do the surgical video part. I would just go through. It's the same thing. Going into removing as much bone as possible, then opening the opticocarotid, going into the basilar, opening the membrane of liliquest. So these are all from different parts of the world. Okay. Yeah, but at the end of the day, this is how the brain looks. Okay, even the tightest brains after the cisternostomy, this is how this looks. So Question is, can the brain trauma benefit from microneurosurgery? Answer is yes. This is the in 2008, 2009, this is something that I developed, how this animation, how the cysternostomy works. So there is SH, and the cisterns send out all the fluid into the brain, and then we open the cysternostomy, then they come out and the brain comes. This is called a CSF shift edema. And this is how we describe, this is how we explain cysternostomy at that time. And I guess now it's proven. This is the G lymphatic system, the CSF shift. This is all extensively written about. I wouldn't want to bore you with all that. But the most important thing I wanted to tell you here is we figured out how the brain is cooled. These are all sinuses, and the sinuses are aligned exactly around the largest CSF space. And when you take a breath, what happens is there are small openings into these sinuses, and because of the Bernoulli's principle, the velocity of this breath going into this sinus is very high. And that way the sinuses, the mucosa evaporates. And when the mucosa evaporates 4.2 degrees cooler, that is what happens, latent heat of evaporation, just like a car radiator. So the mucosa evaporates, and then this place becomes 4.2 degrees cooler. And at the middle, the suprasellar cisterns are there. The suprasellar cisterns becomes 4 degrees cooler, and the Virchow-Robin spaces are around all these vessels. So when these vessels pulsate, it is not capillary action, it is Archimedes screw principle. Because the vessels pulsate, this CSF goes into every single millimeter cube of the brain. So this is something we published in 2017. Okay, it is in Springer's Neuroseries Springer, Physics of the Mind and Brain Disorders. It's in 2017, almost 10 years back. So we described this almost 10 years back, and we published it. It was a landmark paper. Still then, people didn't know how the brain was cooled. This was a beautiful principle, and that's because we described cysternostomy and figured out that CSF was going in through the Virchow-Robin spaces into the brain. So this is a chapter. It's a great honor. My co-author was Margarita Beltran, who was a Spanish neuroradiologist. And then came the other chapters and papers. The evidences came obviously later. And this was a landmark paper from Calgary. So this lady is from Nepal. This is the work and the group with Garnet Sutherland. They did a weight drop experiment to prove CSF shift edema. And these are the results where they proved that actually after the injury, the systems are full of blood and the brain has fluid inside. All the CSF goes into the shifts into the brain. So the cysternostomy definition is letting out CSF from the basal cistern. It's a microneurosurgical procedure, and it reverses the direction of CSF shift instantaneously, decreasing the brain swelling by reducing. Can you see this? Can you see this?
Yes, we can see it.
Yeah, so by reducing the pressure in the paravascular spaces and brain interstitium and preventing the cascade of secondary brain injury. So this is the concept of CSF shift edema. This is cysternostomy, and that is decompressive hemicraniectomy. It is also published. Thank you very much. God bless. And I think you should have Parthi talking about the rest of it.
Thank you. I'll
stop sharing. Any questions or anything, I'll be able to answer. And I think Parthi will go ahead and answer. Talk to you about all the techniques and other things.
Are you able to see my slides?
Not yet.
I'll just check it up.
Yeah. So any questions from the audience while the slides are being set up?
Are you able to see this now?
Not yet, sir.
Not? Okay.
No, we're not able to see.
Oh, yeah, right.
Now you can see, yeah.
You're able to see mine, right?
Yeah, you can see it now, yeah.
Okay. Yeah. Okay. I think the innovator has already told about this one. Basically, it's introduction of microsurgery in brain injury, right? Not often we do it, but we do it for hematomas, mainly for hematomas, but not beyond that many times. But cystinostomy is basically a microsurgical procedure. Everyone have to understand this. This is a very important point. And you have seen the surgical videos. This is for the beginners. You have to understand this particular anatomy here. This is the Lilliquist membrane, right? This Lilliquist membrane divides the supratentorial compartment here and then the infratentorial compartment. So this is the basic, right? Now the CSF is here. Whenever you want to shift the CSF from this place, we have to open here and we have to open here also. So this is basic. Now you can see this picture here, whatever I has shown, but now you go through this picture. So everyone has to see this anatomy very clearly, and you have to reach the Lilliquist. Many times, many people ask us, how do you do that? That is very important. By practice, certainly everybody can do it. But only thing is there are few steps you have to do it, and you should understand this anatomy. This anatomy is easy to understand because we are neurosurgeons. We are learning about aneurysms and also skull-based tumors. So we know about subfrontal approach, we know about TDN approach, which are very classic ones. Now, you understand this basic diagram here. We all know about it. There are a lot of regular neurosurgeons who just go to the theater in head injury patient. You just open it without a microscope. You have no clue because the brain is bulging out. You can't reach there. But if you have a microsurgery, you're going to see it better. And as I've said, you have to go very close to the cistern. If you want to go to the cistern very close, you have to remove the lesser wing of sphenoid as much as possible. So this basic, every young neurosurgeon should understand this. So microsurgery and skull-based approach. But then how do you do that? Before that, I was talking about, we call this as a complete cystinostomy only when the supratentorial compartment and the infratentorial compartment is open together. Now, if we do only the supratentorial, you can still have infratentorial load of CSO. Many people ask this question. I know that this diagram has been drawn. I knows about it. And we had a long discussion about this particular diagram because this become a key diagram for everyone to understand. Now, if you just do it only at the opticocarotid cistern, it's not complete because still the edema is there. You will have infratentorial locked up CSF, which is not going to completely take out the complete CSF. That is an important point. That is why this diagram was drawn. And this also coming into the textbook of neurosurgery, B. Ramamurthy book, which is in the new edition. It is coming. Now, another important thing is that we all see Taj Mahal into different way, in a different directions, from the front, from the back, so like that. The cisterns has to be seen in a different way. Because many times you see the young surgeons place the head in a position and then start the skin incision. That should not be there. So every time you move the head from frontal to the lateral side, the cisterns also changes. So that concept we have to keep it in mind. With this concept, you can see here. Now, if you see the cistern here, frontal will look different, pterion will look different, and further lateral is going to look different. So this has to be understood beforehand. So you have to have a good knowledge about the skull base, that is about optic carotids and beyond that. Now, we all know about the pterion approach. Pterion approach is a very common one. Everyone knows about it. But the most important thing is that I always, we used to discuss, me and I used to discuss about this. Please start learning operating with a 3-point fixator. And you must position the head in such a way that you are doing an aneurysm surgery. This is a very, very important point, because if this part, that is the vertex, is going to look above, you cannot reach the system. So unless you position, so this must be the first criteria. Whichever way you have a head injury, whatever may be the thing, but the position must be like what you do for aneurysm surgery or a skull base to go for a suprasellar lesion, right? So that is the most important thing. You cannot keep the head in a different way and then try to do the approach to the cisterns. It will never come. It's impossible. After positioning, you cannot turn back. So that is important thing. And this I has described. You see here, I've done a large craniotomy, like a frontotemporal. You see the pterion and drill it down up to the anterior clinoid as much as possible, as close as possible, so that you can reach the cisterns very easily. Now, once you do that, you can see here very well, like I has shown this. Here is the optic nerve. You can see this is the optic nerve. And if you look here, just between the optic nerve carotid, you can see the liliquist. And just open the liliquist, and then you can put your tube. So this base, this must be like step 1, step 2, and step 3, and step 4 in quick fashion, as much as possible. The more you get experience, the better you become a cystostomy surgeon. Now it looks like we have to call ourselves like cystostomy surgeon in trauma. Then you need to have this basic. That's why the surgical techniques are very important. As you see here, here is a patient with frontotemporal. You can see here a contusion with edema and very severe edema. This is after surgery. You can see the bone is placed back here. The bone is, everyone asks, how do you put the bone back? When you start letting out the CSF, you can see the brain relaxing. Once it starts relaxing, automatically you will have enough space to put the bone back. So that is important point, because you are not letting out the CSF and the brain is bulging, many people throw out the bone. So you don't throw out the bone, keep it with you. The more the CSF comes down, the more the brain becomes lax, and you can see such a beautiful anatomy. Then you should know about this anatomy. You don't need to give, as I was telling you, don't give too much of pressure, just gentle, step by step. The moment you get the first CSF coming out, you can find out everything. Here you can see here, see the CSF here, chiasm there, carotids there, and then you can see the liliquis, it is lateral to the carotid. Sometimes we cannot, as I told you, we cannot reach between the carotid and the optic nerve, but sometimes you may have to go little lateral. Still you can make it. You can see it's the basilar here, and this is the posterior in this case. Now, one more, you can see the one more case, subdural here, hematoma here. This is post-operative. Very lovely results. You have to experience it. It will take some time for you to understand. Again, you can see the position. Please watch the position. It's just like skull base. I am repeating it again, and again. Before you make an approach for your decompressive craniotomy or whatever may be the thing, see that you can do a good positioning. Once you put the position, then all the technique become much easy, much easier. Here is a complete exposition of the decompression and the cystostomy as a whole. Here you can see that very beautiful placement of the this one. I mean, you can see here how we place the tube. The tube has to be gently taken and then placed. So the more you experience few cases, by 10th case, you realize, yes, it is doable. The first case you may be, but then take this particular symposium, this webinar is going to be very useful for those young guys who are watching it, because subsequent after Ayub Cherian has mentioned, I'm seeing my videos, repeatedly we'll be showing the videos. Repeatedly, any number of videos you can watch here. There is not even a retractor there. You said I'm not using the retractor, I'm just using the cotton patties. And then slowly, you can tease out this arachnoid. The more the arachnoid comes, the arachnoid is teased, the more the CSO comes. Wash with saline. Don't be use profuse saline and bring out as much as subarachnoid hemorrhage as possible. The more it comes out, you find the brain is relaxing. Just watch this video, you can understand. Slightly speeded, it is actually slightly more speed here. Now here, this is the optic nerve I'm left that you can see here. You can observe how we are using our instruments. It's absolutely microsurgery. When you do for elective cases, it will be different. But when you do in trauma, it is slightly different, because on the left hand, whoever is using the suction or the retractor, you find the pressure of the brain. If the arachnoid, if the pia is intact, you can surely find it. But if you tear the pia, then you see the contused brain or the edematous brain coming out. So you should be very careful using these patties. The patty is very important. And the more the patty you use, the better for you. When you see these videos, you can see the 2, 3 videos I show you, you really appreciate the surgical technique. So this is one such case. You can always uh, keep using the saline irrigation. I always used to mention, I also used to say earlier days, saline. Now you can see the brain here. See the brain, how lax it is. Though you have a subarachnoid hemorrhages, at the beginning it was pretty bad. But after you do a good irrigation and CS of let out, the brain becomes lax. Where it will not become lax is only when there is a irreversible edema which has already set in. Those cases you can see if you want one more such case. This is a much better case. You can see here. Yeah. You can watch that here. I'm using the retractor very gently. And then patty coming. Watch that. Most of my approach is only with the patties. And believe me and I have done so many of this type of programs. Even at the WFNS, we had a separate session. Everyone asked, how do you do it? How do you do it? The doing, how do you means first is the position. The second is the skull-based approach. The third is the very meticulous way of reaching the case, retracting the frontal lobe. So everything you can watch here very easily. We are able to just suction. Suction should not be very powerful. Suction should be mild, adequate suction. Don't use profuse suction, because powerful suction will pull out the perforators in the posterior fossa. I mean, the moment you remove this lily, this is where now you can see me opening lily. So when you have a very powerful suction, you may pull out the small vessels, which is very dangerous. So you have to be very careful. The suction must be limited, just enough to take out the CS. Watch that. So that's why I'm showing many videos just to make all of you understand. One more video, and I would like to show this. Just have a look. Very simple way of demonstrating.
अब हमें धम्म देश में कौन करेगा भगवान?
Subfrontal approach.
कौन होगा?
This is just a subfrontal approach.
आपका गुरु तथा मार्गदर्शन आनंद इस संसार में कोई भी वस्तु हमें कितनी भी प्यारी क्यों ना
this video is just to show how nicely you can do the arachnoid and the approaches. Because many times we see only elective cases. We don't see a trauma case. So this video was done very early when we started. I think I remember these videos. These are all there in the web. I think it is there in the my YouTube also. You watch this technique. This is the important thing is for all the youngsters to learn this technique. How we tease the arachnoid, how we cut the arachnoid, how we use the patty, how much suction to be used. Now you can see very well. Optic nerve, carotid. The more you dissect, you find the triangle there. So go there, Liliquis is there. You can see beautiful Liliquis. And you can use any instrument. In earlier days, I was using this hook. Now I use different hooks, different type of, whatever you have, the best ones. Now you can see the basilar artery, right? When you keep on seeing these videos, many times what happen is there are not great teachers next to you. Then you find it difficult. So if you see these videos repeatedly, you master it. And here you can put your tube. Yeah. Even interoptic space. I just do enjoy my microsurgical dissection. The brain gets lax by itself. You can see the pituitary stalk there. So this is a moderate edematous patient, but then it does very well. Post-op, you can see very fast recovery. Amazing. Now you can watch here. This is a cerebral edema. Post, put back your bone flap. Similarly, you can see the edema, then the put back your bone flap. Very, very easy, lax. Another case. So we have so many of cases to show, and the ICP drops down very significantly immediately. These are the diagrams which we use it for the techniques to demo. As I was telling, you can do a small opening and then you can always remove the CSF very nicely. You can watch here. It's a small opening. Though this is a big, still more smaller, this is after decompression. So we can keep on showing you any number of videos very live, and people have to take some interest, particularly young generation has to take the interest to start doing. Watch this position. It is something like for what you do for aneurysm surgery. So these are the examples. You can see the pressure before and after. So lax. These are the ICP monitoring. You can do it. Even in children, you can do it. Pediatric. Many people used to say, "Can you do it in pediatric?" Yes, you can do in pediatric. In pediatric also you can do. And this is one such case which we operated in pediatric head injuries. That was a very good result. So only when we have this type of, here also we have done a cystinostomy. Please watch him. I just don't know, but this patient didn't survive. So this patient came maybe after irreversible edema. I have taken it for cystinostomy. I think I like to stop here because all other things are our results and experiences. Just for the technique, I like to conclude this. Thank you very much for listening.
So thank you, sir. Thank you, Dr. Aip and Dr. Parthivan. Excellent talks, and actually, this concept of cysternostomy has revolutionized brain injury care, because many of the surgeons have started adopting it. We have seen many centers doing RCTs, and people publishing reviews and systematic reviews and meta-analysis. So this has gradually got the acceptance, and now more and more younger people have started doing. Initially, it is very few people are ready to accept, including myself. When I used to see the videos of yours and of chairing the conferences, Even I could not believe that you can put a bone flap back. So it's a standard technique in humans or any book or any teacher taught us that you have to remove the bone flap and put it in the abdomen or the bone freezer. It's changing. It's changing now, and it's changing for the good. So thank you so much. So meanwhile, there are some questions. Um, I think Mr. Subir they has typed that what are the complications you have faced during cystonostomy? So Parthivan sir, can we start with you? Any complications that you have encountered?
Uh, 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 I don't think any complication. I always used to fear only one thing. I just wanted to, in fact, I wanted to know about Ives feeling also. Whenever I do cystostomy, there's no complication. Means I'm not to say any complication, not even the vascular injuries. I'm talking about, you can see the carotid and then posterior fossa. We're going there. We have the only thing which I find something. If I say complication outside, the suction should be meticulous when we go beyond Lilliquist because of the small perforators that come from the posterior. That is the one which, so what I will do is I always keep the lowest suction at that point, though slightly little bit higher on at the carotid level. But when I go beyond Lilliquist, I keep it down. I have only one scare in me is that now in case if I find an incidental aneurysm sitting there, that is the one. So I always now started keeping one, clip, one set of clip, because I don't know. Though Ipcherian was doing he got as a serendipity, he was approaching as an aneurysm. It keeps coming in my mind because we were discussing it. We do not know. There is an injury. Okay, we go for a cystoscopy. All thing is like an aneurysm surgery. We are all neurosurgeons. Tell anyone who can say no. This is completely an approach for an aneurysm surgery until to the basilar tip aneurysm. If you remove the PC, like what Ipcherian does, then it is like a for basilar tip aneurysm. So that is the only one scare I used to have in the back of my mind. It should not be anything, you know. I don't
So
know
that,
what
sir,
I.
there is one very
But
interesting question.
if
Have
we
you?
Sorry?
don't have a angio scan, it is very difficult for us perioperative decide where we are going to plan our clipping or whatever. And most of the time, it is our history and the rest of the features which decides us. As you said, very, very rarely you may encounter in that situations. But even if you have the clip, without knowing what is the the physiological anatomy of the aneurysm and its neck, we won't be of much help in that edematous brain
Yeah,
period time. That's one.
So
I don't
there
know.
is
It is
one
it's always
interesting
in my
question.
dream, in my mind, because the more you do it, you start thinking various things. In one of my case, I found the posterior clinoid was broken. It was damaged. I was seeing that
Trauma.
intensity of the
Trauma.
PC was fractured. This is
So,
a
how many
pretty.
cases of post cystonostomy you had to remove the bone? Had you had any such cases? After a few days, you had to remove the bone.
I had two cases like that, I can say. The reason for that is maybe um, there was some edema. In spite the CSF was coming, we saw some shift, some changes. So I was forced to remove in two cases of such cases, but they settled down. Probably I should have waited.
No, it's difficult. At times, we will not be able to make a complete decision not to remove. If it hits on
Yeah.
our face, there is some residual edema. Maybe because of
Yes.
cytotoxic, which sets in little later, and we had to. And have you
Actually,
shifted
so
over to minor, small craniotomies now compared to the large craniotomies what you do before after starting
yeah,
cystotomies?
my opening has started coming down. Now we make very small. And the bigger the opening we do, because if there is a confusion, you want to remove some clot associated. Otherwise, not needed. Not very much needed. That's what
So
I think
the
hypothesis.
standard part is always to do a larger craniotomy in all trauma.
Yeah.
But by the introduction of cystonotomy, if we are getting quite less CSF, and as I have shown, the skull base approaches allows you to let out more CSF when we reach up to the liquest, then naturally the size of the craniotomy also should decrease.
Yes, that's
Except if they come late, after 4 days, 5 days, when they come late,
so that's a bargain. I mean,
the
even
infarct sets in.
you start doing 20, 30, and then maybe you can think of reducing size. So you begin with at least,
Yeah,
maybe
yeah,
you
of course.
start with
The
large,
earlier you have to be at a bigger size, nothing wrong in it.
and
I will.
specifically the injury is kind of acute.
Yeah,
You know,
the
it's after
electrical
2 days.
thrombotic.
Yeah.
So there is an interesting question that one has asked, that you ever tried this cysternostomy in ischemic stroke cases? As for
No?
physiology, I think it is of no benefit. But I have you ever tried it in ischemic stroke cases?
Yeah, I have tried, and the thing is, I never found any benefit. So after 12, 13 cases, I left it. But I was surprised to see that there is a group. You must check out this paper by Massimo Cardali and group. Massimo Cardali and group.
Hmm.
What they've done is, immediately after the intervention window is over, and before the cytotoxic edema sets in, they did cystonostomy and they got fantastic results. So instead of waiting for the cytotoxic edema to come up, maybe after the intervention window is over, after 6 hours are over, then instead of doing nothing after the 6 hour window is over, you could go ahead and try cystonostomy. So these days, we are going ahead with acute STMCs and cystonostomy. This is something that we are doing right now.
Good.
Yeah,
Very early.
what I have observed is like if it's an MC infarct or IC infarct and you are landing up with the frontal lobe completely infarcted or the temporal lobe completely infarcted, even the necrosectomy to reach up to the cisterns and letting out the CSF after the necrosectomy also gives a sufficient volume of space and CSF release to help in the ischemic. So, though you cannot call officially as a cysternostomy, but basically you release the CSF to let out the edema to subside.
And what is your criteria for removing the drain? When you prefer to remove the drain? That is one question that someone is asking me right now.
Drain.
Yeah, drain. When you remove the drain, sir?
I,
Yeah.
You mean removing the brain?
No,
Drain.
drain. The
Cysternal
CSF
drain.
drain.
The cysternal
CSF
drain.
drain. Yeah.
Yeah, so first 2 days when the CSF is bloody, I keep the drain at the same level as the ear. And then the next 3 days, I keep it higher so that I never drain more than 180 ml per day. That is the absolute limit. More than 180 ml per day is over drainage and it is also dangerous. So, not good. So 2 days at the level of the ear, about 180 ml will drain. The next day, the next 3 days, it will drain much more. So that is very counterproductive. So you need to raise it to about 15 centimeter height. You can do it on a IV line. And after 5 days, you remove it.
Okay.
actually, initially, this drain is very interesting, actually. When you keep it, suddenly you find there won't be any drain. It won't be coming in. Nothing will come. Don't get scared because after you open it and then you're closing it for some time, sometimes it never drains. And suddenly I get my call from my residents or sir, now it is draining very nice, sir. That is in the night or early morning. Suddenly it takes a pressure and then start draining it. But there you should be very careful. As I was telling, over drainage is very, very not a good one. So it has to be around 150 to 180. More than that, sometimes it just flows out. I've seen in few cases just flows out. But if the subarachnoid was very, then the flow is very, very limited. One should know how to handle the drain also. We should be careful because the handling of the patient by nurses should be, you have to instruct them that here is one more, because sometimes you have the drain there, you have the ICP monitor So a lot of things are there. So we have to explain to them because drain in the subarachnoid space, not many people were aware. Some people will think it is just a drain, subgilial drain. So we write the cystostomy drain. The instruction is separate for the nurses. We have to teach them also where exactly this because if we don't keep it properly, it may slip out on the second day or third day, particularly when the brain laxes further. So should be very careful.
So I have a question to Dr. Ayub and Dr. Parthivan specifically that regarding the cases with extensive skull-based fractures and the ACP is fractured, do you still suggest that we should try cysternostomy or just safely decompress and just come out because you don't have an angio to rule out an aneurysm?
Okay. Oh, the question is interesting because it's talking about auto decompression, right? Autocystostomy. In skull base, sometimes you find the CS of leaking out. In fact, I used to say that is the God has done the cystostomy by itself. Through the nose, you can see. In those cases, even if you open it, you find the edematous brain will come. I'm not very sure how much CSF you get it. In few cases, there were not much of CSF was coming out from the systems. That was my observation in those type of cases. I'm talking about the basal skull fractures.
Yeah.
It leaks. Sometimes it comes from the ears, sometimes comes from the nose. We don't get much of CSF when we go for the. What's your experience in this?
I'm not really worried about the vascular injury because I think all the junior chaps who are listening, in just before I went to the US, we had uh, two cavernous tears. We were going transcavernous, and one time the meningohypophyseal artery tore, and another time one of our colleagues he was handling he was handling a pituitary he was handling a tumor, probably an nasopharyngeal carcinoma, which was encasing the carotid, handling the carotid tore. So the whole thing is, if you understand that a crushed piece of muscle is magic, actually it is really magic. So a crushed piece of muscle, you put it onto the carotid, and this is endonasal. I mean, if it is not, then most of the time you can repair or bypass. It's not of course, people has again to have a mind shift of, can you do a bypass in trauma? Yes, if you can expose the basilar, if you can do a anterior clinodectomy, posterior clinodectomy, you can very well do a bypass as well. So it's all about the mental pictures that we make. Even any tear, any vascular tear in any skull base, I wouldn't. I wouldn't be worried about doing a cystonostomy. But as Parthi said, if there is already CSF leak, it is auto cystonostomy. God has already done cystonostomy. Yeah, you don't need to do. You don't need. These patients do very well. In fact, skull base fracture patients with, there is a paper that says that skull base fracture with CSF leak and in severe trauma, these patients do very well. So one thing I dislike is safe, whether in my life or when we're going off-roading or when we are operating. Safe is a very relative term. Sometimes safe is the most unsafe term. Okay, so we have to ask neurosurgeons. Safe means that unsafe is actually stupid. Sometimes you go and do stupid things that you shouldn't do. I mean, other than that, you should go and do anything. Whatever you think you can do confidently, without, just because your teacher didn't do that doesn't mean that you cannot do it. You can. I mean, that's the whole purpose of teaching somebody. I mean, my students, for example, Afsal or anybody who's learned from me, should be way better than I am. Otherwise, there's absolutely no point in teaching. So let's not. I wouldn't do that. Whatever is skull base or whatever. I've had cases where I've had injuries, and we had to. Sometimes we could not control it, but that is early in my career. But today, if I have a carotid tear, I wouldn't be unduly worried.
Thank you, Professor Aip and Professor Pratibhan. I think it's very nice talk, and both talks are, that we'll record and put on YouTube for, multiple time watchings. There are some few quotes, some papers that Ipe has quoted, and there are some words that actually we have to catch upon. Like, the work on the stroke that I have to look, what people are doing right now, and these things are, really, really very interesting. So from NTSI, from the Neurotrauma Society of India perspective, I would like to thank you both. And I wish that your association with the society will remain, and will try to have more of these talks on our, on the platform, on the this internet platforms, and as well as in our conferences. And you have been always, a source of support to all our trauma conferences type, and I'm really thankful for that. So
Thank you.
I
Thank you.
think we can close this session, and I'm very thankful to Dr. Chinmay and Dr. Vikram also for taking up as panelist on very short notice. And Dr. Pratiman, you are one of the legends. Then we can always look up as younger persons, not so young, but still younger than you. So thank you so much, sir. Thank you so much. Thank you. Good night to you all. Thank you.
Thank you. Good night, all. Thank you so much.
Thank you. Thank you all. Thank you all.
Thank you all. It was an honor. And of course, we'll be always associated with the NTSI. It's an abs. Thank you, Deepak. Thank you, Vikram. Thank you, Parthi, for calling me for this. Thank you, Chinmay. And thanks for everybody. I hope the youngsters move more and all over the world, not just in India, but all over the world. Youngsters go ahead and do this. One more thing that I wanted to tell the youngsters is, when you do this, is something that is abundant in your country. Not only are you helping your patients, but you're helping yourselves also, because instead of going and seeing basilar tip exposure in some Western place where you fold your hands and you stand there, as soon as you finish your MCH and you learn how to expose the basilar, you learn how to do skull-based principles. You don't have to go do fellowships in other places anymore. Your expertise in vascular and skull base is going to, your level of neurosurgery is going to go very, very high. Obviously, that should not be your first objective. The first objective should be to help the patient. But when you help your patient, you are helping yourself as well. This is another corollary that I would say. So thank you so much.
Thank you. Thank you a lot. Thanks.
Bye-bye. Good night.
Thanks, Das. Thanks, Afsal. Very nice.
Hello. Great to
Thank
see you.
Yeah, see you all.
Bye-bye.